So for the first abstract or presentation, we reported outcomes in high-risk patients who were treated on our phase 1 study of CLAG-M, which is salvage chemotherapy, administered along with lintuzumab-Ac225, which is a radio-labeled antibody against CD33. So this is a phase 1 study that was conducted between 2019 and 2022. And during this period, we enrolled and treated 26 patients with CLAG-M, which is cladribine, cytarabine, and mitoxantrone. And then afterwards, lintuzumab-Ac225, which is a radio-labeled antibody against CD33. During the period of enrollment, we enrolled patients particularly with two high-risk features. One, patients with either poor risk cytogenetics or a p53 mutation. And so specifically poor risk disease, we enrolled I think about half of patients with that. Secondly, we also enrolled a fair proportion of patients who prior to treatment on this study received a venetoclax-based combination. All of them had received ven-HMA, either venetoclax with azacitidine or decitabine. And this is an emerging sort of difficult to treat population in AML. There have been recent studies that indicate with subsequent therapy, very few patients can respond, between 20 and 30% achieve a response with a subsequent therapy after failure of NHMA. And survival overall is very poor, in the range of about 3 to 4 months. So a critical need is this population. So for this presentation, we identified 13 patients who were treated previously prior to CLAG-M lintuzumab with ven-HMA. Of these patients, we found the majority of these patients had mutated TP53, which is unsurprising because overall that represents sort of a significant resistant or refractory population amongst AML patients in general. So with these 13 patients, the majority of these patients were treated at what we determined to be the maximum tolerated dose and the recommended phase 2 dose, which is 0.75 microcurie per kilogram. So of these 13 patients, 4 were treated at that dose. And then the second half, so a significant proportion otherwise, was treated at 0.5 microcurie per kilogram, which is the dose below a recommended phase 2 dose. Again, of these 13 patients that were treated with ven-HMA previously, 9 had a p53 mutation, 10 overall had adverse risk AML by ELN 2022 criteria. And then just in terms of the breakdown, there were 2 patients who received CLAG-M lintuzumab after frontline ven-HMA, another 3 patients who received CLAG-M lintuzumab as third-line therapy, so after some therapy and then ven-HMA, and then another 8 patients who received this treatment beyond the third line. And so that was the breakdown of patients who received this treatment. What we found were patients who received CLAG-M lintuzumab after ven-HMA frontline therapy. Actually, all patients, those 2 patients both responded and both had MRD negative responses. Of the 3 patients who received ven-HMA as a second line or as a first salvage therapy, 2 out of these 3 patients, or 67%, responded. Both of these patients were MRD negative by flow. And then finally, of the patients who had received this as subsequent line therapy, so either fourth line or beyond, we still saw a modest response rate. 3 patients responded for a response rate around 37.5%. Overall, for this difficult to treat population, we saw an encouraging survival. So if given this therapy, median survival overall was 7.3 months. In patients who had either received venetoclax-HMA as frontline therapy or first salvage, the median survival actually was not reached at 2 years. And so this is a pretty effective salvage as either first or second salvage after ven-HMA based on this limited population. Finally, amongst TP53 mutated patients, of which there were 9, we saw a response rate in We saw responses in 5 patients, or 56%. If they achieved a CR, these were all MRD negative CRs. Overall, their survival was modestly improved compared to historical outcomes at around 7 months. So the overall sort of message with this abstract is that really the hardest to treat patients with relapsed or refractory AML now are those patients who fail venHMA, and particularly those patients with p53 mutations. When we looked at these sort of difficult to treat patients, or these patients for which there's a high need for salvage, we saw pretty encouraging outcomes, particularly the fact that half of these patients with p53 mutations were able to respond, survival beyond what we kind of historically see around 3 or 4 months as well. All in all, sort of supporting that this combination should be further investigated in a definitive fashion in either a phase 2 or phase 3 study.